Today we are delighted to have Dr. Elbert Huang from the University of Chicago and Dr. Elizabeth Lynch from Rush University, who will be presenting their research on social networks of community-based organizations and researchers in Chicago. We're also honored to be joined by an expert panel, including Karen Bolin-Stovall from the Illinois Institute of Technology, Pat Lyons from Endeavor Health, and Dr. Daryl Jenkins, who is founder and pastor of the Faith Community Church. So we are presently called Endeavor Health, formerly North Shore, and the Outcomes Research Network was established 5 years ago, and it was structured in a very strategic way with academic clinical leadership and to really catalyze research across our enterprise, but also across the 6 Institute for Translational Medicine academic communities. Our goals have been to enable uniform, high-quality community access to care that's effective and efficient and equitable, enrich the practice of medicine for our clinicians, and support strategic clinical quality and operational decision-making using outcomes data. The objectives of our series are to disseminate research that advances the implementation of health equity in our health systems, health equity in our community, policy change to promote equitable care and outcomes, and to advance translational science. We also want, as a result of this, and the information and the connections to have flourishing clinical investigators and promote a culture of collaboration and team science. Culture change can take a long time, but over time with relationships, we hope that this does foster a number of new collaborations. And we want to bridge researchers together across their peer community and across Chicagoland, and ultimately deliver outcomes research that improves patient outcomes and health equity across our communities. Next slide, Rachel. Oh, first of all, most importantly, I'd like to introduce Rachel Rewington, who is my co-pilot in the seminar series. Rachel is an administrative assistant in outcomes research. And I'm Sean David. I am a family doctor, but I'm also vice chair for research and a program director for translational science and site leader for the Institute for Translational Medicine. And Dr. Huang, Dr. Lynch, and I work together in the community and collaborations cluster. Okay, next slide. So the learning objectives of today's seminar are to understand social network patterns in Chicago's CER research ecosystem and how to measure them, learn about how the Chicago Chronic Condition Equity Network is building a community-based research network and the goals of the CBRN, and to understand the barriers to engaging community partners in research. And it addresses an unmet need of helping physicians understand local efforts to engage communities and research and how to get involved. Next slide. We also, as a clinical and translational science CTSA awardee, we have several translational science competencies that we'd like to address through our series. And there are 8. We feel that this really addresses all 8 of them because it addresses creativity and innovation, focuses on unmet needs, generalizable solutions across multiple communities, and is a great example of cross-disciplinary team science, done very efficiently, and it's bold and rigorous, and promotes diversity, equity, inclusion, accessibility, and it's really boundary crossing across metropolitan Chicagoland. Next slide. Rachel, I'm going to hand this off to you to talk about continuing medical education credit.
Thank you very much, Dr. David. Hello, everybody. To mark your attendance and claim CME for today's session, text the SMS code that's listed on the screen. The University of Chicago Pritzker School of Medicine designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credit that corresponds with the extent of their participation in the activity. Other healthcare professionals will receive a certificate of participation. The opportunity to claim credit will open at the start of today's seminar and will close after 30 days. Credit cannot be retroactively granted beyond a 30-day period. Therefore, it is important that you text in promptly after the seminar to successfully claim your credit. The CME flyer is attached to today's calendar email and will also be emailed to you along with more instructions on how to retrieve your CME credit after the seminar. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see the image to the right, you can choose to message either the panelists and speakers. This will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you're experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you as best I can. I'll now hand it back to you, Dr. David, to go over the agenda for the day.
Rachel, thank you very much. So we're starting off now with an introduction. Following that, we'll be introducing our speakers and they'll be presenting at about 10:40, and that will go for about 35 minutes or so, give or break 5 minutes. And then we'll have a Q&A session. During that time, we ask the participants, those who are logging in as an educational activity, to put comments into the comments section throughout the talk, and Rachel will then feed those comments to our speakers. After that, we'll have what we call an Incubator Hub expert panel discussion, where we have a multidisciplinary panel reflect on the presentation and address how what the health equity implications are for implementing for our health systems, communities, policy, and translational science. And we'll have some closing remarks. And Rachel will also talk about how this will be uploaded on our YouTube channel. So if those who missed this want to get the CME credit or build it into their training programs, they can log in tomorrow and do that. So I have the privilege of introducing two of my colleagues, Dr. Elbert Huang, who is professor of medicine and a professor of public health sciences. He's also a primary care physician, and he's director of the Center for Chronic Disease Research and Policy, and associate director of the University of Chicago Center for Diabetes Translation Research. He also has a number of other hats and is a real leader in practice-based research network. Dr. Elizabeth Lynch is professor of preventive medicine in the section of community health and director of preventive medicine at Rush University Medical Center. She also wears many hats, including a Live Faith Network and United West Side Chicago. And I'm going to stumble over all of the words, but she had a huge impact on the West Side of Chicago with health promotion and prevention. And so I'm honored to introduce both of you. And Rachel, should we queue up their slides? Okay. Dr. Huang, Dr. Lynch, it's all yours.
Thank you, Dr. David, for that kind introduction. So I'll start off the talk. Next slide. So Dr. Lynch and I will basically divide this talk across this outline. I'll begin with a background discussion around why thinking about social networks might be helpful for us in thinking about community engaged and community-based participatory research. I will describe a study that I have done with one of our medical students at the University of Chicago, as well as some sociologists, describing kind of the research that has happened in Chicago over the last 10 years, and showing the social network patterns in the community engaged research ecosystem. Then Dr. Lynch will take over and talk about how that background research has provided the inspiration for our efforts to build a community-based research network, which includes collecting data from community-based organizations, as well as data from researchers. So what is a social network? A social network is a network of individuals that are connected by interpersonal relationships. So you, as an individual listening to this talk, you have a social network of your own family members, friends, and coworkers. We all live and work, and our whole society is bound together by these networks. Social networks, it's important to say, exist at multiple levels, and sometimes these levels interact more than others. So certainly, community at an organizational level, let's say let's say at the level of a church, sometimes churches know about each other, and so community-based organizations can have their own set of networks. So going beyond the individual person up to an organization, organizations have networks as well. Sometimes different professionals have also their own kind of work, their own network of other professionals. So nurses have connections with each other. Similarly, doctors and other healthcare professionals have connections with each other through their professional networks inside of their own organizations, but also outside of their organizations. It's also important to think about, back to the last slide, that clinics and hospitals also have different networks. So clinical network, let's say a health center network, may have its own internal connection network of clinics, but it also may connect with other networks of clinics. And then hospitals and health systems like Rush or University of Chicago, they may have a network of hospitals and network of clinics as well. And then researchers also have their own networks. These are the connections between other researchers. So within a city, some of us collaborate and work together. But in all these cases, it's important to say that some of the social networks sometimes there is actually both collaboration, but there's also competition among these different groups. Next slide. So that's just the background around kind of the idea of social networks. Community engaged research, and I'm just trying to provide some background about community engaged research, brings together people and entities across these the different groups that I talked about earlier. So community engaged research brings together community, healthcare systems, and researchers. There are, however, some challenges to carrying out community engaged research or sustaining community engaged research. So from the community perspective, what happens is that researchers come and go. And sometimes a community a community member or community organization will notice that researchers from the same organization are not coordinating their efforts. So they'll say, "Oh, didn't you? I just talked to Bob last week. Didn't you know about Bob, Joe?" And so sometimes researchers will approach organizations in the community without coordination. Frequently, community notices that researchers come with questions, and the questions don't necessarily come from community. From a public health perspective, there are a number of other challenges of community engaged research. Sometimes we are conducting community engaged research with sometimes the same organizations, and because they are willing or because we happen to know about them. And so we may approach the same organizations repeatedly. And that runs the risk of not sharing opportunities for research or sharing learnings from research across the whole community. And without some coordination of community engaged research, there's no collective knowledge of what projects worked and what did not work and what should be scaled across our community. Next slide. So how can social networks combined with community engaged research provide some new insights into how we can do things better? So the problems of community engaged research are frequently due to lack of sustained funding and lack of coordination. And so because we have a world of research that doesn't have anyone centrally organizing the research, we end up with something called a hollow core. So I'm just featuring this book that comes from sociology called Private Interest in National Policymaking. And what these sociologists did was they studied actually how policymakers in Washington, D.C. Actually have the same kind of failure of coordination in different areas of policymaking. So they actually studied 4 areas of policymaking, and they found that there was actually no one actually coordinating policymaking across these 4 different areas. So the hollow core that they describe refers to the fact that this kind of network of policymakers lack brokers with a capacity to bridge the 4 domains. And so we started looking at social networks and community engagement research because we had this hypothesis that the same thing may be happening in Chicago related to community engagement research, because there is really no central broker within the network to organize activities, to ensure sustained funding, and to provide coordination. Next slide. So I want to show you some basically background information from a study that I conducted with a medical student with a sociology background, a graduate student, Jake Burchard, and then Ben Cornwell, who is the chair of sociology at Cornell. And so this explores the community-based participatory research ecosystem from over the last 10 years. Next slide. So in this study, what I'm doing is I'm equating the term community engagement research with community-based participatory research. I'm saying I'm going to use those terms interchangeably. So our knowledge gap around this area is that usually people focus on an individual project, the conduct of a single project, and most of the published literature focuses on the outcomes of those individual projects. But there's actually very little effort to understand the overall community-based participatory research ecosystem, which means, which is the broader set of interactions between research partners across multiple projects in a given region. And when we don't actually look at the overall ecosystem, we will miss redundancies, there will be inefficiencies in the way we do research, and we won't be able to know if we have good representation across all relevant parties, disease groups, ethnic groups, different geographies of different sections of the city, without sort of taking this look at the ecosystem. Next slide. So this study is essentially a review of published papers. So there are going to be limitations to what we can say about the ecosystem but a published paper in some ways represents the end product of community-based participatory research. And so we looked for, we found 500 articles published in the last 10 years that mentioned community-based participatory and Chicago in the paper. Next slide. And then we sort of cleaned up these papers and limited the data set further. Next slide. And we focused on 128 articles that fit our inclusion criteria. Next slide. And within these papers, there are actually 415 unique authors and organizations, and there are 220 unique Chicago-based contributors and organizations, and 46 unique projects in these 128 articles. Next slide. So this gives you a picture of what the social network looks like across this community engaged research ecosystem. You can see in this picture, the green dots represent different academic institutions. The pink dots represent different distinct projects, and the blue dots represent distinct community-based organizations that were actually mentioned or were authors of in these papers. And this gives you an idea of how big the network can be, and it shows you how there are many connections between these different types of entities. And one of the measures that we use in social network analysis is degree centrality, which basically means how many connections does a given node, we call each of these circles and squares a node. So a node that has lots of connections has a higher degree centrality. Next slide. So this is just a summary of the publications I described earlier, the 46 projects, the different number of contributors, and you can see that there are a lot of community organizations represented in these publications, over 120. Next slide. Next slide. Very good. So this is the overall ecosystem from this 10-year look-back period, and you can see it's a kind of a dense set of connections, lots of different projects, but you can sort of see that on the periphery there are some sort of random projects that don't seem to be connected to the central core. Those are actually projects that were conducted by people outside of Chicago who are using Chicago organizations. The green dots all represent academic institutions, the orange dots are projects, and the blue dots are individual community organizations. Next slide. So I'm going to show you the network as it appears for 3 different disease areas. So this is the network for the Diabetes Research Network. This shows projects that relate to diabetes. You can sort of see key projects such as the Southside Diabetes Project, the Little Village Project, and you can see how Chicago played a role in both Little Village and the Southside Diabetes Project. There was a separate project, looks like it was led by Northwestern and UIC in the northwest corner. And then there's a separate diabetes project out to the right, to the bottom right, that's isolated, not connected to the rest, led by Rush. And you can sort of see that it's not a very big network. It's actually, there's only, on this picture, only, I'm just doing a little bit, 8 projects that are in this network. So that sort of tells you about how much funding was available in diabetes and who worked with who in this diabetes network. Not a very big network. Next slide. On the other hand, the cancer network is much bigger. This shows you the number of projects, which are, there are many more orange dots. And you can sort of see that the key academic institution is actually Northwestern in this. You can see that Northwestern is the has the highest degree centrality in this cancer network. And you can sort of see that some of the projects have large numbers of community organizations connected to them, such as the Chicago CHEC project. There are sort of other networks like connected with Chicago projects that are out to the right, and there's an isolated network up to the upper left. Next slide. This is the third slide, the last network I want to show you, which is the asthma network. This is interesting because it's actually a relatively small network. There's only 5 projects featured, but you can sort of see that each of the academic institutions, Rush, Northwestern, UIC, and those 3 academic institutions seem to be coordinating better across, seem to be well connected across all the major projects in this asthma network. So we can actually probably spend a lot more time sort of dissecting and understanding these networks, but it shows you what disease areas are well studied, what are not, which have lots of community organizations, which do not, and which networks have lots of partnerships and which ones have less. So I'm going to pass this on now to my partner, Beth Lynch.
Hello. Good morning, everybody. I'm going to follow Elbert's discussion of social networks by talking about a infrastructure that we are building, and this is, by we, I mean seeing the Chicago Chronic Conditions Equity Network that Dr. Huang and I lead, as well as the Community Collaborations Cluster of the ITM. So, okay, so I'm going to start this by just telling you a little bit about some of our work that we've done through SEEN, our center, in trying to understand what community members think is important, like are the most important health priorities in their community. And so we've done a series of town halls where we have gone and spoken to residents on the south side, the west side, and the suburbs around Aurora. And what we found there was that mental health is the most important health issue. Second most frequently mentioned is chronic health issues. And then among the top mentioned health priorities, 50% of them were social determinants of health. So things like housing, violence, et cetera. And then the Chicago Department of Public Health has also been doing work, working with community organizations across the city to understand health priorities in the communities across the city. And that work resulted in these top 3 priority areas. So behavioral health, public safety, and chronic disease. Next slide. So in that context, we have been building this infrastructure, which is we're calling a community-based research network, in order to increase the the number of partnerships between researchers and community members, particularly around developing interventions for health equity. And so what do we mean by community-based research network? So this sort of emerged out of the ITM work with Dr. David, Dr. Huang, and myself. And what we realized as we were going into the most recent grant cycle for the ITM is that you know, each of the institutions that make up the ITM have community partners that they work with, and they also, many of them, at least University of Chicago, Advocate, and North Shore Endeavor, have practice-based research networks as well. So we thought, what if we attempt to coordinate better across all of those various partnerships across these institutions and build an infrastructure that kind of links them all together into a broader network. Next slide. So the reason for doing this is because we believe that, you know, we all know, we haven't shown slides on this, but I'm sure you have seen data showing the dramatic health disparities that exist in Chicago, in particular life expectancy. So Black Chicago residents live 10 years less than non-Black Chicago residents. And so these are pretty dramatic and horrifying data that we want to address in our research and make ourselves useful to public health. So in order to improve health equity research, we believe that partnering with community organizations will improve the research that we can do. And so what this CBRN, Community-Based Research Network, is composed of is community organizations across the region. We're building this now, who are research ready. This is the ultimate goal. So we will, we're working on ways to train these organizations to be ready to conduct research with academic partners. And these organizations will have research topics that they're interested in pursuing. And we will be holding some events to offer opportunities for researchers and community organizations to have conversation and potentially come up with research ideas, which I'll talk more about later. And so we have right now a community engagement staff as part of SEEN and ITM that helps facilitate partnerships with researchers and helps sustain relationships with community organizations outside of particular research projects, which is always a challenge for researchers. When the funding isn't there, it's hard to maintain those relationships, and then that leads to lack of trust among the community organizations. Next slide. So the way we're going about this is, as I said, we have a community engagement team consisting of Lisa Kuklinski, Christy Edwards, Joshua Rawls, and Willie Love. And they are in the process of conducting one-on-one meetings with community organizations to build up relationships and trust with those organizations, and also identify potential research opportunities with the organization. And also, at the same time, we are working on leveraging the resources of the academic institutions to support community-based organizations. So how do we give back to those organizations? Well, many of our institutions have programming that they do in the community. And so if we can sort of direct those resources that our institutions have towards these community organizations, that helps build trust, and then sort of also increase the efficiency, right, with which the institutions partner with the community. So a lot of the work that institutions do with communities is not research, it's programming, right? Investing in the community, the surrounding community. So if we can partner those efforts with our efforts to build research partnerships, then that's a win for everyone. And so one of the things that we're doing is conducting a survey of community organizations. The purpose of this survey is to collect information about the community organization. So what kind of programming do they have, and what populations do they focus on? And part of this survey, we're also asking about what are the top partnerships that each organization has with other organizations. And so I'm going to show you some initial results of that in a moment, but this survey was developed, and we ran it by the Community Stakeholder Advisory Council of SEEN, our center, and got approval from them, and we've been collecting data since the summer, last summer. Next slide. So this shows the social network data of these community organizations that we have in our database so far. So it's hard to see what's going on, but you can see that there's like a little group up there on the left that isn't connected, at least in our database, with these other organizations. So one of the things that we can offer to these organizations is to invite them to partner with each other as we identify organizations that may benefit from potential partnerships. So not only partnering with researchers, but also partnering with each other to improve their services. Next slide. And so you can see here, as I mentioned, we are, when we're doing the survey with community organizations, we're asking them what types of programming they do. And so we have broken down here the social networks, or the networks among these community organizations based on the different type of services that they're offering. So you can see that these networks have different characteristics across these different types of service. Next. Okay, so the other thing that we're doing here, as I said, we're building this infrastructure to support relationships between the community partners and the researchers. And so what happens when you begin to partner with community organizations, and when I opened this part of our talk by showing you the health priorities of the community, what you see is that there are a range of health priorities that exist in the community. And so what this means is that no single researcher is going to be well positioned to address all of those priorities of the community, right? So we're kind of trying to flip what often happens on its head. So what I think happens normally, and I think we saw that a little bit in the networks that Elbert showed, is that researchers often have a set of community partners that they work with. And so they work with those partners, and sometimes the partners are working with other people because they're, have high capacity and so on. But often researchers just have their partners, and that's who they work with, and they don't particularly want to share those partners for good reason, because you don't want other investigators to come and risk your relationship that you've built with these partners, et cetera. However, to respond to community need and priorities and the huge multifaceted barriers to health that are experienced in some of the most disadvantaged communities in Chicago, we need a multitude of researchers with different skill sets working together, partnering with communities to address these issues. So that's really what we're trying to do. Also, as young investigators, it's often hard to build community partnerships. Say you're new to Chicago or you're just new to the field. If that infrastructure isn't there, it's really hard to get into this kind of work and start doing this work. I can speak from personal experience that's what happened when I was more junior. So in addition to engaging with community organizations, we're also engaging with investigators. And so I know there's a number of investigators on this call. And so I encourage you to fill out our investigator survey. So we have developed this survey to start building a database of researchers who would potentially be interested in partnering with community organizations to conduct research. So these are the people listed here who have worked on this survey from within the Institute for Translational Medicine. And then we've also been working with the Chicago Consortium for Community Engagement, which is C3, and that's the organization of the community engagement focused investigators within the CTSA programs of Northwestern, UIC, and the ITM. So we're trying to maximize our reach across the city to all the research institutions so that we can engage them all. So the purpose is to, as I said, identify investigators with experience and interest. So you don't necessarily just have to, you don't have to have experience. And then we're also in that including a social network portion where we ask about past partnerships with CBOs to build upon the network data that Elbert discussed earlier. And so we just opened this survey and we just started collecting data. I believe LaDawn Jenkins put the survey link in the chat, and I'm going to show you a QR code for it too. So I hope everybody who has any interest in this type of work, you don't have to have experience in it, but please fill out the survey. Next slide. Okay, so I'll show you, we have 40 researchers that are in our survey now. So I'm just going to show you a little bit of detail, and it's kind of exciting how varied the researchers are in our database. So you can see Endeavor North Shore is so far the winner for the most number of people. And if you guys keep going, you may stay the winner if you, enter yourself into our database today. And so you can see we have a representation of multiple research institutions across the city. And most people had either a MD or a PhD, 15 years of experience in research. And then you can see the research focus is nicely aligned with the health priorities that I showed you earlier. So we have a lot of people interested in mental behavioral health, chronic disease, and also violence. Next slide. And then so we also, and this also is showing you what the questions are that will be asked. So we also are asking about social determinants of health that people have experience with or are interested in conducting research on. And 70% had previous experience with community engaged research. And so you can see that 30% did not. Well, you're the people also that we want in our database so that we can help you connect up with community partners. Next slide. Okay, I just saw that it's not working. I hope that's, oh no. Well, that's frustrating. So we will send out the link later. Dr. David will send it all to you. Yeah. Please fill it out.
What isn't working? Sorry, what isn't working, Beth?
Apparently the link isn't working, I'm seeing in the chat, but maybe we can get it to work before the time is up today. Oh, Chris, so maybe it's only working within Rush, because it looks like somebody from Rush.
So you just
Anyway.
take the camera, right, and then push the link. Is that, take a picture of it?
Well, there's a, yeah, so hopefully we can, please call the person who did it now, and maybe she can fix it. So hopefully she can
I
fix
think
it.
the community-based organizational survey link does work. The
Hmm.
research investigator survey does not work right now. So we'll fix
Yeah,
it.
so
Oh, maybe is that one closed or is that still open? Research investigator.
I
should
don't know
be
what's wrong with
open.
this. I'm not
Yeah,
sure.
we're gonna
what's wrong
fix
with the
it.
investigator
We're
report.
gonna fix it.
Okay. Got it. Thank
Okay. We'll let you know when it's fixed. Thank you so much for trying, everyone. Okay, there's just a couple more slides and then we can. Okay, so next steps are that we will fix this survey so that you can use it. So I apologize for that. And then the information we collect in both the researcher survey and the CBO survey will help us make those connections. Also, I wanted to mention here that we're planning a series of convenings where we will be inviting community-based organizations focused on providing services related to the high priority health topics from the community to present their programming, and we will invite researchers to those events and hopefully stimulate conversation and potential collaboration. So if you haven't really worked closely with community organizations, it's quite impressive, some of the work that's going on in the community. And it's unfortunate that researchers are often not familiar with what's going on. So we're trying to change that. And so, so next slide, I think I have to. Okay, yeah. So the next one will be on April 25th. We don't have exact time or location yet, but it'll be on mental and behavioral health. So if you're interested in that topic, please come. We'll have organizations that are focused on prevention, intervention, and policy, and have lots of conversation and networking. So we're really excited about this, and we will definitely share the details with you as they become available. Next slide. Okay, and then finally, next slide. So within our center, we've been working with the community. One of the things we did is the town halls that I told you about, where we got information from the community about what their priorities are. We also have a advisory board that consists of a number of community organizations and F2HC leaders from the area. And so that advisory board helps us expand our partnerships to other stakeholders. They also review our mini grant and pilot award applications that we have through the center, and then supports dissemination of requests. So when there are RFAs that come out and we want to do research and partner with community organizations, then they help get that word out. And so there's been really good impact working with those partners on our research. So one of the things that has occurred in our work in the center over the past like 2.5 years is that we've realized we need to expand beyond cardiometabolic disease. The focus of our center is cardiometabolic disease, but there are many other factors such as violence and mental health that clearly impact people's ability to manage any cardiometabolic conditions they have or prevent them from happening. So we've expanded our focus beyond just the specific condition of our focus. And then, as I said, our community partners connect the center to other organizations, helping expand our reach and network. And then they've also participated in current interventions going on in our center. Next slide, thanks. Okay, and so this is pretty, I've covered a lot of this, but so we have in the center our investigator development core, and as I said, our advisory board members provide input on our request for proposals, what we're interested in funding and prioritizing in terms of funding, and also review the grants and decide which of the specific proposals will be funded. And then we have 3 interventions within the center, and one is called VITA, and in that there were 2 healthcare organizations that were involved in designing and implementing the project, and continue to be involved throughout. Engage as well. I'm not going to go into the details of these studies, but that was also designed through a participatory research process with older adults who are the target of the intervention. And then the Keep It Moving study was done in partnership with the Alive Faith Network, which is a network of Black churches in Chicago. And they played a major role in the development and evolution of that and implementation of that project as well. So the community partnerships have really enhanced our ability to do research that's responsive to the community and is implemented in a way that makes sense to the community and hopefully is sustainable in the longer term. So thank you. That's all.
Fantastic. Thank you so much. I will say that we're collecting some questions. So participants, please enter your questions to our speakers. And as someone who's had the privilege of working with Dr. Lynch and Dr. Huang, I think this is the most exciting project in our ITM because it really bridges together everything that we are trying to achieve with health equity. It's also very bold, and Dr. Huang and Dr. Lynch went ahead and got a separate grant to fund building the guts of the CBRN before the ITM 3.0 even started. So it's incredible what they've built. And and this Community Stakeholder Advisory Council is represented by members of our panel at Endeavor, Live Faith Network, and Illinois Institute for Technology. So we have an opportunity to talk to some of the CSAC during our panel. And I was just going to ask both of you if you had some thoughts about the overlap between these surveys and the awareness and engagement surveys that were done last year that looked at level like net promoter scores and that kind of thing. Can we learn from that in any way on how to maybe improve engagement for the CBRN? Kind of an abstract question, but thoughts about how should we focus on people who are already engaged, likely to use the network, or do we need to go outside?
Researchers? Are you talking about researchers?
I think researchers and research staff as well, so that they're really telling other investigators who are doing their community-based research efforts about all the resources and the networks that already exist, including longstanding relationships with the CBOs that you and others and Pat Lyons and so forth, and Karen as well, and Pastor Jenkins. How do we have common knowledge so that people aren't starting from scratch trying to connect with community organizations? Because there may be some great relationships and trust built over a decade or more. So love your thoughts about that. Maybe we can talk about that in the panel too.
I think you're well, I think, Sean, that I think you're alluding to this prior survey that we did actually that you organized earlier on, and I think we are always building on we're always growing the network based on who we know already, and so I think we always are building on the existing network. It's growing, it's changing. So I think it's been every point of contact we have with either community or with researchers is beneficial. And but what we collect and whether or not we are successful in engaging, I think we are always, Beth will talk more about whether or not we're successful engaging people is another thing. And how to measure that is also interesting.
Mhm.
Yeah, I think there's a lot of, I think, you know, if it were easy, probably someone would have done it already, maybe. But so one of the things that we need to really think a lot about on the researcher side is, and I mentioned this earlier about why researchers don't always want to share their community partners, is because you know, it does take some experience. It's like going to another culture altogether, and you know, community organizations are not really cognizant of the research culture. One of the big things, for example, that I've experienced is that, you know, when we try for a grant, we scramble, and there's a deadline, and we get the grant in, hopefully. Then we wait, right? And then like a year or something, right? And then suddenly there's all kinds of deadlines again. And so that's not really how community organizations work, and it can be a little disconcerting. So that's just like one example of the culture difference. So I think we're working on kind of training just to assure that the work that we do building trust with our community partners doesn't get undermined by lack of experience among the researchers, or vice versa.
Great point. We do have some questions now in the, Rachel, would you like to take those on?
Sure. Our first question, Dr. Lynch, is it possible to obtain names of research-ready CBOs focused on specific SDOH in the short term for upcoming grant opportunities?
Well, we welcome you to reach out to us. So the process that we're going to use is not to just connect people directly to the organization, but to serve as a liaison between the organization and us. So please reach out, and let us know what you're interested in, because we do have a lot of organizations now. They may not be research ready yet. Some of them are, but yeah, reach out for sure. That's exactly what we want. So
Yes, please. Yeah, we have a team that can that's ready to meet, that knows the organizations, and that's exactly what we're looking for.
Okay, thank you.
Yeah.
All
I
right,
think
next-
also increasingly, oh, sorry to interrupt. Increasingly though, as we've become one big network ourselves, it's not a matter of inside outside. It's more a matter of look at our registry. Go ahead. Sorry, Rachel. Go ahead.
Oh, it's okay. Next question. What research topics of interest have emerged from the community? How do you have an RFA process, but also incorporate research interests of community members?
Well, so the slide that I showed earlier, I wouldn't say that the community has research topics like, to them, they're just priority issues, right, that they want addressed. And so how to turn those into research topics and research questions is an interesting question that we're working on, how to facilitate that process among the community organizations, because it takes a long time to know how to formulate a research question, right?
Yeah.
And then how do we have an RFA process? Do you want to answer that one, Elbert?
Yes, I can. So you know, it is a challenge to try to keep on the timeline that the sort of the way that grants are organized and funding is organized is on a schedule that doesn't fit neatly into or it doesn't match very well with you know, building trust with community and developing true partnerships. But what we do is in the pilot grant opportunities, they're actually reviewed by both an investigator and also a community member. So each pilot grant is reviewed and they have equal weight in terms of the assessment. And there's actually a special measure for the level of community engagement in the grant. So some people come to us already with good community engagement, and those grants are viewed favorably. And we also provide additional funding if there's a community partner we add another $10,000 to the pilot award. So we try to do we try to use economic incentives, but also our review process is informed by community and for every pilot grant that we review.
Okay, thank you.
I just want to say that there is a link from LaDawn Jenkins for the investigator survey that does work. It's in the chat. I don't know exactly how to circulate that in a more effective way, but that link does work.
Oh, sorry. Maybe you can put up, instead of this slide, the QR code slide.
The QR, it doesn't work. The QR doesn't work.
Oh, the QR code doesn't work? Oh.
QR doesn't work.
Towards the end, I'll circulate it again. What I'll do is I'll put up the link again throughout, like towards the end. And when I do circulate the talk, I'll make sure to swap out the QR codes with the correct link so we get all the information correct. You're welcome. Okay, we have 2 more questions. Are there any internships available for MPH students?
Great question.
Yes, I'm sure we could. Yes.
I mean, I think that we definitely have this is the network overall has a lot of opportunities for trainees of all of different backgrounds, certainly MPH students. You'd have to connect with someone with a project, with an organization, but we don't actually have an explicit internship program set up, but we have all the pieces in place that we could.
We did, yeah.
And we have multiple, right? There's multiple MPH programs in Chicago at UIC, and then Chicago has a brand new MPH program that I'm involved with as well. So yes, we are very interested in creating more opportunities for trainees.
The other thing too is go ahead.
Oh, I was just going to say that we didn't really talk about this very much, but the city of Chicago has created what they're calling health equity zones, which are groups of organizations working together, doing needs assessments of their community, and then planning intervention strategies. Now, it's not necessarily research, but I think a great role for an MPH student would be working with those health equity zones to identify potential research opportunities.
Yeah. The other thing I was going to add as well, that the ITM funds a TL1 postdoctoral fellowship in health equity, informatics, and something else. But that includes masters in public health programs at Loyola Rush and University of Chicago. And we do have some TL1 fellows on this webinar right now. So if anyone's doing their MPHs, for example, it makes sense that, there's alignment with that. You know what I'm talking about, Beth, and Albert. So
yeah, it's actually kind of exciting to hear about the interest of students, because that we really need that pipeline of people to eventually become active community engaged researchers.
Yeah.
Thank you. Our last question, have you compared your town hall areas of need results with each healthcare institution's community health needs assessment in those service areas, assuming they concur?
We have not done that yet. We have looked a little bit at the CHNAs, but I think that's actually a great idea. So thanks for that idea.
Yeah, we need to build our army to have a lot more people to take on these projects.
Yes.
Because
That's right.
we really, that's part of the goal, isn't it, to have citizen scientists and
Yes.
trainees at every level involved with capstones and things like that. So these are great things to take on. Okay, is that the last question, Rachel?
That is the last question, yes.
Okay.
Thank you.
Okay, so yeah. Well, thank you both for a really inspiring presentation, and it's just so exciting what you've been able to build. And so next, I have the honor of introducing our expert panel for our Incubator Hub. Karen Bolden-Stovall, a recent presenter for our seminar series, is a community research and training director for the Illinois Institute of Technology, and has co-developed and developed an incredible network of community health workers focused on mental health and peer counseling and a whole range of different things. So Karen joins us today. Thank you. And Pat Lyons is a program manager for health equity for the North region of Endeavor Health and quality and health equity for Endeavor Health. Dr. Daryl Jenkins is founder and pastor of the Faith Community Church. And Karen, Pat, and Pastor Jenkins are all part of the CSAC, the Community Stakeholder Advisory Council. So welcome all so much for joining our panel. And you've had a chance to listen to the presentation. I'm sure you have a lot of thoughts. And so now we get to do really the fun part, which is to have that conversation about all the implications of this work for how we can implement results from this to advance 4 areas, starting with health equity in our health systems. So this is an open discussion, but to our panelists, including the lecturers, what are some of your thoughts about how we can better implement these kinds of insights, or maybe what we will learn in the future by talking to more communities in our health systems?
Thank you, Dr. David. I'd like to share some thoughts. I think that this seminar was a great start to collaboration and really talking about how do we advance health equity in our health systems using the research. I think we need to share information. We need to share the research studies that are happening and disseminate that information to all areas of our businesses and collaborate across health systems, similar to what we're doing with the CSAC and the C3EN, making sure that we combine as health systems to share what are you doing in your area? Maybe I can use that information. How do we partner with our community-based organizations to get the word out about our initiatives and how we're trying to help populations?
Thank you. Pastor Jenkins, are you?
Thank you. Can you hear me okay?
Yes, we can. Thank
Excellent. Well, let me just first of all say a special thanks to the conveners. I've had the privilege of working with Dr. Lynch as well as Dr. Huang, and what a great experience I have had in working with them. I think what's really key, the takeaway for me, is that from a social network standpoint, the congregation, and I'll speak from the perspective as a clergy, as a faith leader, within the communities of faith, there are varied backgrounds. It's very intergenerational, cross-cultural community. And what is key there is that you already have a built-in social as well as a faith network, as well as the community network. Saying that it's important to understand that within that network, there's an old saying that your network is your net worth. Your network is your net worth. And so having said that, I think that there's a net worth of invaluable information, data, and research that will help to mitigate the health issues and disparities that we're discussing, particularly across diabetes, asthma, and the cancer areas that were spoken of earlier. And so I do want to say that engaging of faith leaders is important and, quite frankly, necessary, but cannot be engaged from just a transactional perspective. I think it has to be a relational transaction versus research-driven. Someone earlier mentioned that the researchers come and go. And I think when we talk about building trust, there has to be a long-term sustainable relationship. And let me just say, I was excited to hear about the internship question because there are persons within local congregations that are MPH students or social services students. And I think it creates a wonderful linkage to the research and the community of faith.
That's really exciting. Thank you so much. And Karen, you have some thoughts to share?
Yeah, I wanted to chime in, and this will probably lead us really well into our next question. I think in terms of health equity and health systems, one of the things that is continuously, sometimes a challenge is sometimes it's easy to think of people as numbers if you're dealing with a high volume of service, right? It's really easy to kind of quantify it that way. And it's really important that, when we're working with people, that we think of them as people living with a health condition. My background is primarily in peer support and mental health. I'm a peer. I've lived with anxiety and depression for a really, really long time. And one of the things that really strikes me is usually when I'm, with engaging with a provider is that I'm asked kind of like these basic routine questions, but not asked about my feelings about it. And I think it's really important that when we're working with people that we really focus on the relationship that Pastor Jenkins was talking about. I also think in terms, when we go into the next question in terms of community, Beth really did a great job of talking about this, is that we, as researchers, spend a lot of time in doing outreach to community, but not really doing engagement. It's really important to build those relationships, and the conversation should realistically start, long before there's a grant you're hoping to put together, right?
Yeah.
And the other thing is, we need to do a better job of releasing that information to the community, but not just releasing it in a way that is digestible for people who do not have medical degrees, people who do not have a high level of formal education. I primarily work with people who have, a high school diploma or less. That doesn't mean that they can't necessarily understand what's happening in the research. It just means that we need to change that linguistic piece. And I think sometimes that's also what's getting lost in the translation. Thank you.
Dr. David, Dr. David, can I react to what
Please.
Mr. Karen just
Yeah.
mentioned? I do think, just to build on that, to walk alongside of her, key is to working with the CBO that lacks the knowledge to put forth the research work that is considered unique to the zip code that people are in. The research culture, the language, the various nuances of, and I come from 60628, and many don't know I'm from the south side of Chicago, 312 area code. And I would tell you that it's so important that that research culture, as well as the language, is clearly understood. And so I want to commend ITM, Northwestern, Rush, and UIC, and others for helping to unpack the pain points in the community in a language and in an understanding of a culture, because more often than not, it's us, them, and it's a separate language, it's a separate cultural conversation. And so I just really want to say that I think it's very, very helpful to continue to build on those collaborative talks.
Yeah, thank you. Yeah. Mm-hmm.
Sorry, I just also wanted to chime in really quickly about the relational piece, especially in communities of color. I've worked in research for a while. I am a Black woman who lives on the south side of Chicago, and there has been a lot of damage done to the reputation of research in communities of color, especially Black communities, especially Latino communities. I'm someone who was very hesitant at first to get involved in research and very hesitant to get involved in mental health, just because of the stigma attached. I have relatives who have been, experimented on, who were locked in mental institutions in the 30s. And that kind of continuum, that kind of understanding of what happens to our families, to our communities, is very much ingrained in our history and in our interactions with researchers. And while I understand, we all know Tuskegee, it was shut down 50 years ago, but that is, within my parents' lifetime, it is still a consideration that I think about. And so it's really important that when we're doing those interactions, that when we're having those conversations, that we recognize that we own that, and we pay credence to that, because I think that's something that we really saw this last go around, especially with COVID, is there was a lot of hesitancy, right? There was a lot of lack of trust for not only the research community, but also the medical community. And we do great work. We're really advancing towards getting to a point where we can have open conversations. But that's something that we're still genuinely working on. And I think that's really important.
Thank you. I just want to say from a personal standpoint that you talked about networks, Dr. Huang and Dr. Lynch, but there are cross-cultural networks within faith-based institutions. And as this is really not about transactional, how many numbers do we get for the grant, and that it's I see this as being a gateway to healing too. It doesn't stop with the research paper. It does never stop. It's just, how do we heal our community together? And so I think without engaging with the faith community, all faiths, interfaith community, we're really missing a big healing vector that's very powerful, and Karen can testify to that, and I can testify to that too. But this is ultimately about healthy communities, not about getting the R1, although that's important too. So we can do more of this. Okay, well, I think it's time to segue into health equity in our community. And Dr. Huang and Dr. Lynch, feel free to also contribute to the conversation if you're still on at any point. So going into this now, so we're not an island. We really are nested in communities and struggling to figure out how to best engage with cultural humility. So how can we implement results from this research to advance health equity in our communities? Thoughts for, start with Pat, because I know you've done a lot of work in Evanston in this area.
Sure. I think Pastor Jenkins and Karen brought up some very good points with the previous question. It really starts with establishing a foundation of trust and making sure that you are marrying what the research and what the data analysis says with what the community's priorities are and what are important to them, which means addressing social determinants of health, recognizing what's important to them, and it leads to a healthy community for that specific area. That can include addressing chronic disease or something like a food deficit. So I think that that's one way to show that you're invested, to also celebrate the milestones. Like most research projects, it might be a 2-year plan, a 3-year plan, maybe 5-year. But if you accomplish something along the way, make sure that you're circling back to the community and saying, hey, with your support and intervention or your feedback, this is what we were able to find. This is how this benefits you. And not just, to Karen's point, it be an experimental experience where they feel like guinea pigs ultimately. So I think trust is huge with getting the research to be incorporated in the community, getting them to want to participate. If you don't have a diverse group of subjects, interventions might not be as impactful as you would want them to be. You have to get multifaceted, multiracial people to participate. So I always say trust and collaboration.
Yeah. Dr. Huang, Dr. Lynch, I look like you're ready to jump in. Anything to add to that? I mean, clearly trust is a big factor, and it takes a long time. And I think that by showing up and actually delivering on some of these SDOH issues, I think it does begin to inch towards that. But I know for Dr. Lynch, I don't know if you want to talk about the Alive Faith Network, for example, but you've really done quite a lot with that in the West Side.
Yeah, and in fact, part of the idea, I think, for this infrastructure for the community-based research network came from our work with the Alive Faith Network. And, I certainly will not take credit for that. I've partnered, myself and some colleagues were presenting to a bunch of clergy one time at Rush, because it was a sort of community outreach event that Rush had, and we talked about lifestyle and health, prevention and so on. And one of the pastors in the audience basically took me aside and said, "Oh, we really need more of this because the pastors are really stressed and taxed, in the community." And so we basically started by working on pastor wellness, and it wasn't research at all. It was just helping the pastors, supporting them to support each other, really, is what happened. And we did a retreat, and we planned this all with that pastor and 2 of his pastor colleagues. And in fact, Dr. Jenkins was part of that initial cohort, which is how we know each other. And so that just evolved over time. We did multiple pastor wellness programs, and then the pastors really wanted to extend what they were experiencing in terms of shifting their focus to take better care of themselves and extend that to their congregations. And so that's when we started working with them to develop interventions for the whole church. And So it's been really successful. And but what happens is then you develop an intervention, and it's successful. You work with a couple churches, and you're very closely tied to those churches. We worked with most of the churches initially we worked with for a year or two. We had just the luxury of having that time to build relationships. And then now we're doing a much bigger study that requires like 60 churches, and we have to do it in 3 years. And so we don't have that opportunity to build those relationships. But we still take pastors on retreats, and we do as much pastor wellness programming as we can. And so we really have built those relationships. And it's not me. I mean, I don't have the time. I mean, I was more involved earlier on, but LaDawn Jenkins does a lot of this work, and then Pastor Epting and Pastor Jenkins also. So we have a lot of pastors who are working to build this network. So, but what we learned is that we really have to build these relationships between, that last above and beyond the research study, and that are not just about the research study. But at the same time, as we all know, the academic sort of incentive structure isn't really aligned well with that. So there is some degree of sacrifice, probably, the researcher to do that.
Yeah, thank you for that. It seems that a lot of health systems now are authentically trying to figure out how to be better at connecting with communities too. And so there does seem to be an opportunity for bidirectional learning, or at least health systems learning from the communities, if we can figure out the right way to do it. I know Pat has been working in that area for a long time, and it seems to me that there's also silos that may not be intentional, but you've built an incredible network. Our community navigator for the ITM for the North region, Corliss Davis, has also met with about 80 different community partners as well. There's a wealth of relationship building, but it's still somewhat fragmented. So how to get to a point where this is a we proposition for everybody would be, I think, the ideal, because then it's not the pointy-headed academic people observing communities. It's how do we learn together? How do you teach us to be better community researchers, ask the right questions, and be responsive? And so I'm learning every day what I don't know about how to do this, but there's so much that I think to get to that point of integration would be really exciting. All right, so why don't we move on to the next discussion question, which is how can we implement results from this network to promote policy change for equitable care and outcomes? So this could be at multiple levels, from the health system outwards to CDPH and the state and federal even. Any thoughts about policy change? Yeah.
Yeah. So one of the things that I do is I do a lot of the CBPR trainings at IIT, especially for community members. And one of the things that I think we need to get better at is connecting research to policy, right? Because that's the big driver, right? We have these pilot studies. We can sometimes have these huge projects that involve hundreds of people, but if we don't move it to the next level and get that in front of policymakers, then the system doesn't change, right? So I think one of the ways to do that is to really be much more engaging than we are. I think part of that, though, is because we tend to kind of focus on the academic papers, right? That's something that we have to do, something we all have to do. We've got to write, we've got to get it out there, but also really making sure that we are keeping in touch with the policymakers in a way that is relational, the same way that we do with community members. I also think one of the other things that is perhaps one of the things that we're still working on is getting our community members, our communities, to see that research can help drive that policy change. I know Beth talked a little bit about it, is that, when we're engaging with these organizations, it's really important for us to remember that almost always they are social service organizations. They are driven by, what does my community need right now, right? Not 5 years from now, not 10 years from now, right now. And one of the ways to get them to have that buy-in, to have that understanding is, I know you're here right now for your community, and I know that you're trying to do something right now, but how do we fix this so that you don't have to keep doing this for 20 years. Grad school first round, I had a great professor who was an executive director of an organization. He told us our job in social services is to work ourselves out of a job, right? That's kind of the whole point.
Yeah.
And so how do I get community members to see that working with me now on this research project will mean 10, 20 years from now, they won't have to be working on these same issues, that they'll be able to advance and move forward. And I think the way to do that is to really be clear in that communication, talk about that, but also we need to bring in the policymakers. Now, that doesn't necessarily mean elected officials, but that means that we do need to bring in those key components so that we're all at the same table and all having that conversation together rather than having it separate and siloed.
Yeah, if I can also just contribute to that briefly, the policy change is intimately connected to the research readiness in my view. When there is clear research readiness in terms of working with the CBOs, working with the communities of faith, and others, I think you then are best positioned to provide the training as well as the guidance to bridge what we were talking about earlier, the transactional versus relational gap. So again, I think policy change begins with research readiness. And then it was something that Dr. Elbert spoke of earlier, and I may not clearly state with eloquence that he had, but there's what he spoke of as a hollow core, right? And when you think about that, from, at least from my perspective, the CBO, the clergies are connectors. They are the catalysts that are going to help bridge the gap, close the gap. And so I think making sure that there's visibility and a voice in the room and in at the table is what will also ultimately bring about policy change to promote equitable care and outcomes.
To piggyback on what Pastor Jenkins shared, I think it's important to recognize that the research paints a story, right? And so how do we use the data to appeal to policymakers and say, this is what our community needs. This is what we need for our most vulnerable populations. These are the interventions that matter, and how we can support that. So that just resonated with me when he said, you know, that those are change drivers. The data tells a story, and we need to make sure that we get that to the highest mountain ultimately.
Yeah, I'm thinking about this panel, for example, is a great example of what if we had someone from CDPH here listening to this too. Maybe we made a habit of inviting someone to join the panel. So there are some ears in City Hall, you know, and some ears at the state capitol. But I want to make sure I don't miss this question from Brittany Adams. Is there consideration in reaching out to the chaplains employed within these healthcare institutions to assist in building partnerships or improve engagement? Some, if not most, are local pastors. Also, the African American sorority and fraternities commit to community partnerships and service.
Yeah, that is a great idea. And actually, we've definitely done that at Rush because Rush has a chaplaincy program. But one of the things that we would like to do is expand our network to the other institutions within the ITM. And so Pat has been helping us with that at Endeavor. And we're working with Loyola as well to reach out to local, you know, pastor partners that they have. So yeah, thank you. That's a great idea.
Yeah, I mean, the fact that we have Pat at Endeavor, who's been working for decades building relationships, is really a key because we don't have to start from scratch, awkwardly trying to connect with CBOs. Right. Okay, well, the last question is, how can we implement results from this to help us do better science? And, you know, I think we can learn so much, we can harvest so much from really observing which things work and don't work in the CBRM. But I think one of the goals was to learn how to do better science. Any thoughts on that, Elbert, Beth? Any of you?
Dr. David, I just want to highlight a comment that Karen made earlier about putting the science and the research into layman's terms so that the community can understand what the implications are. I think that that is super important. They need to understand what the value is, and it needs to be in a dignified way that this information is shared back with them, and how their participation contributes to the greater good of their community, the state, the world, etc.
Thank you.
It was hard to get in the way of the eloquence of Karen, Pat, and Daryl. I just would say that for research, if we are basically facing major issues with high rates of multiple chronic diseases, disability, violence, and so from the research perspective, we have so much. I think we have so much to make better. And I think that one of the purposes of science is to improve the human condition. And I think if we don't sort of, if the scientific community doesn't sort of confront the realities of people's lives, then it's sort of so. Anyways, the fact that there are so many needs and issues, that those are that means that there are some unanswered questions. It could be, maybe we do know quite a bit about what behaviors are associated with better health, but maybe the issue is we are having challenges. How do we communicate to people? How do we do that when their social circumstances are not being social needs are not being addressed? So there's a lot of questions about how to basically convince our communities and large populations to incorporate better ways of living, but it's not so easy, and it's clearly different from neighborhood to neighborhood and community to community. So I think those are all unanswered research questions, mainly around implementation or adoption. But there may be new ways of sort of thinking of how do community assets turn into benefits, or how do community connections turn into interventions themselves. So not thinking of community as being sort of asset free, but actually having resources that we can tap into. I think those are all kind of interesting ways of turning. You can turn almost everything into a scientific question. I think that's important. I just want to actually end with stop my statement with end with a quote I got from a computer scientist who basically later in his career started doing more community engagement in his own research. And he said, there does not need to be a conflict between an intellectually interesting idea, improving the practice, or advancing societal goals. We can do all of those things.
That was beautiful. Pat, did you have another comment?
I was just going to say that one of the things I think that is an issue and that we do need to change in our work is a more focus on sort of community level interventions, which are difficult to do and difficult to measure. However, I think because they're difficult, maybe, and expensive, they just haven't really been tried very much. And so we end up constantly focusing on educational interventions where we just keep telling people over and over, just eat better, just exercise more, and it's like, and Elbert mentioned this, but like ignoring all the structural factors that are really the barrier, right? And so we just need to go upstream a little bit more and work there. And so, I myself am in that situation where I've done a lot of individual level, church-wide interventions, and I think that's really important to do those things, and they are important, but they're not enough, right? We have to go a little bit further back to really make an impact and demonstrate what we keep saying, which is that it's these social barriers and structural racism and structural issues, and we just need the data to back it up and to really understand how do we address these with different interventions.
And I just
Thank
kind of want to touch on what Beth and Pat said. One of the biggest pieces obviously is the structural racism, is the language, but one of the other things to really think about is cultural sensitivity in its purest form, right? Even outside of the structural barriers and all of these other things, especially with cardiometabolic issues, you know, I'm a Black woman. I love soul food as much as the next person, right? If you tell me all of a sudden I can't have my grandmother's dressing, like it's just not going to happen, right? And so we need to really critically think about that, and how do we help people create changes that are systemic, that are also very much in touch with who they are as a people and who they are as a culture. The other thing that I wanted to mention is, you know, our language really does need to adjust and really does need to change. One of the things that happens when I'm doing my first round intro to community-based research for community members is they hate the word investigator. Okay, that's like the #1 issue, because investigator, especially for people of color who I primarily train, mostly Black Latinos, that is a very scary association. That is an association with police. And so we have to think about those things critically. We need to think about it in terms of how do we really reach our communities where they are, right? Because we're not going to get anywhere if we don't get the community to come with us. So thank you.
Thank you, Karen. I had never thought of that. I investigate, but that makes sense. But this is the thing, is the also the accidental implicit bias of just not knowing what you don't know. And so, well, I know we're at the end of our time, and I wanted to thank the panel for a very rich discussion, and also just say that our next seminar will address trauma-informed care. So maybe we can build on some of these insights in that as well. But in closing, Dr. Jenkins had to hop on a plane, but he said something earlier, which is that your net worth is your network is your net worth. And that's definitely apparent here. So thank you for building this network and for bearing with us for an hour and a half. To everyone, I think there's a lot of opportunities for collaboration, and we're just getting started. So wish you all a great week. For questions, you can contact me directly. There's my email. There's an evaluation that we're going to send you with a brief survey after we close out the seminar. And there'll be also, I think there's a link in the chat box to that. Is that there yet, Rachel?
Yes,
if not,
it's
she'll
there.
send it out. Okay, great. And this is recorded, and it will be distributed with a link to our YouTube channel shortly, sometime this week. Rachel, thank you. Thank you, Dr. Huang, Pat Lyons, Karen, Dr. Lynch, and Dr. and Pastor Jenkins for a really fantastic seminar. Okay, enjoy the rest of your week.
Thank you very much. Bye, everyone.